All right, live on YouTube, and we are going. Let's see. And we are live on Instagram. Good morning, Peachy on Ice Daily Show. My name is Dr. Ellison Melrose. I am coming to you today to chat about order of operations within session. A lot of the time on our weekend courses, we get asked about what tools should we use first in the clinic and what should we do after dry needling, or is there a specific order that makes the most sense within the clinic? And our answer is always it depends. And so I kind of wanted to give you guys 3 things to consider when choosing your order of operations to get the best out of that clinical session. So first, let's kind of go over our typical follow-up session flow. At ICE, we believe in symptom behavior models. So we will always be reassessing both subjective and objective asterisk signs once our patient comes into the clinic. So we always want to make sure that we have time for that up front, assessing those. And then from there, once we have that assessment underway, we are going to be choosing our tool for making change. And the choosing your tool is going to depend on 3 different things. Number 1 is your goal of your treatment. Number 2 is the patient's preference. And the third thing to consider would be your preference, or the physical therapist preference. So when we're choosing that tool, we want to make sure that we're always considering, again, the goal of the treatment, patient preference, and physical therapist preference. Once we do our first tool, we're going to reassess those objective and subjective asterisk signs to see if what we did with that tool made a change within session. From there, we can start layering in other tools: manual therapy, exercise, pain neuroscience education. And then ultimately, all roads lead to load. So that's kind of what our typical follow-up session flow would look like. And now let's dive in a little bit deeper about those 3 things that we want to consider when choosing our tool. Let's start with patient preference. So I know this is, we're kind of thinking about what tools do I want to use, but not what tools does our patient believe is going to be the most effective tool for what they have going on. So number 1 thing to consider when choosing what should I do first or which tool should I use would be patient expectation. So our patient expectation is going to drive outcomes that we have in the clinic. So if someone is a little bit more averse to dry needling, it might not be the first tool I choose for them, right? If someone has had a lot of dry needling in the past and has had a very good outcome with that, that might be the first tool that we use for that patient. So that is just one thing to consider, is what is their preference and what do they believe is going to make them better faster, or whatever our goal for that treatment is. Which leads me to the next thing, is goal of treatment. I did a post on social media the other day that just kind of outlined one of the goals with our treatment, or when we should utilize dry needling within session, depending on those goals. So is our goal for our first tool to reduce pain? We might want to choose a tool that is, again, something that might make them feel a little bit better quicker. One of the most efficient tools we have to do that with is dry needling. So we might use dry needling as one of our first tools in that session. If our goal for our treatment is to prime the nervous system, or is to reduce tone, or improve force output, that might change when we use dry needling in that order of operation. And then for the last goal of the treatment would be for recovery, and if we are using dry needling for recovery, it might be the only tool we use in that session or take up a majority of our treatment session if our true goal is just improving hemodynamics, using dry needling as a form of facilitated recovery. So we would either be using that as a main chunk of our treatment session or after something that may have resulted in high and metabolic output that we want to then improve hemodynamics immediately after to improve that recovery. So again, patient preference is going to play a role in choosing our tool. Our goal of our treatment, whether that may be pain mitigation, priming the nervous system, or recovery. But the biggest thing I think that plays a role in choosing your order of operations is actually the preference of the provider or the physical therapist. So this is all an "it depends" answer. But there is often a good debate that occurs during our courses of what should come first, dry needling or spinal manipulation. In our household, being that I'm a dry needling faculty, my husband is a spine lead faculty, we have some opinions about this. So it is a good conversation to have. And I think we're always going to choose what we know and do that first, right? So, for example, immediately out of school, I was doing a lot more manual therapy, a lot more joint mobilization, spinal manipulation. I was treating in California, could not utilize dry needling as a tool there. Once I moved out of the state of California and could start using dry needling a little bit more, I will say my practice evolved, but my instinct initially was always to go with joint manipulation or joint mobilizations first. And so, a reason why a clinician might choose to manipulate first is because we want to crack them when they are crispy, right? So when those joints are really stiff, we might have better access to that winding up the connective tissues and taking them to that mid range to have a really effective joint manipulation at mid range. And I would argue that a reason to maybe needle first would be if that positioning is uncomfortable, or if it's a patient that holds a ton of tone, we're just getting to them to their mid-range manipulation position is uh, uncomfortable, or you just don't feel like you can get to that mid-range positioning very successfully, or you don't have a lot of success on their manips. Sometimes a neck can be a really challenging neck to manipulate. One thing that you can do prior to that would be, again, speaking the language of the nervous system a little bit more with the precision of a needle. So, a reason to maybe needle first would be to help bring down some of that tone that allows you to get to that position a little bit more comfortably. Again, PT preference plays a role, but so does the goal of the treatment. And so I wanted to kind of dive a little bit deeper into if our goal was changing tone with our patient and then going to load in the gym. So if we were using the both spinal manipulation and um, dry needling to improve force output, for example, what would be the optimal order of operations? And I don't really think there's a correct answer, but I'll give you my answer is that the dry needling. So, for example, let's say we're going to go load the glutes and I want to improve glute force output. I'm going to pop a couple needles into their glutes. From there, we can use the neuromuscular priming higher frequency setting on the E stim for our parameters there for a few minutes. So the nice thing about improving force output and neuromuscular changes is that the duration of dry needling is very brief compared to something like mitigating pain. So we're going to needle those glutes first. From there, I always like to end dry needling with a little bit of feel good stuff. So a little bit of soft tissue just to desensitize that nervous system a little bit. And then after that, I want to improve global neuromuscular facilitation with a spinal manipulation. We know from the literature that spinal manipulation isn't very, we aren't, just moving one joint on top of another joint, and we get these global neurophysiological changes. And so for that reason, I prefer to start with the dry needling, improve force output in some of those glute tissues locally, and then manip after that to, again, get a more global, widespread neurophys change as well. So this was a whole discussion on an answer of it depends, and there's not really a right way or a right time or correct order of operations within session. What Coming from the dry needling division, I would want you to challenge your own beliefs a little bit. So if you always do it in the same order, if you always manipulate first or you always needle first, try something different, right? Um, Listen to the patient and see what their maybe expectation of that treatment session is, and see if there's any change in your outcomes if you are either if you're typically a manip first, try dry needling first, and if you typically dry needle first, try some of the other um, mobilizations, manipulations first, and see where your outcomes lie, and if there is any, again, preference, or if you see any change in your within change session um, symptom behavior. Yeah. So thank you guys so much for hanging out with me this morning, just talking about those three things to consider when choosing order of operations. Again, those are goal of treatment, patient preference, and physical therapy, physical therapist preference. Again, there's no right way to do it, just always coming back to our typical session flow, always going back to both subjective and objective asterisk signs, making sure that we're doing test retest so that we know which tool actually did make a change in our patient's symptoms. All right, guys. Hopefully, I will see you out on the road. Upcoming courses for the dry needling division. We have a sold out course down in North Carolina this weekend, and then I will be in Longmont at the end of the month. Last weekend, I will be in Longmont, and I believe Jim will be out in Kansas that weekend. So hopefully, we can see you guys on the road. Have a good rest of your day.